Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Dr. Roland van Kimmenade in Nijmegen, the Netherlands, and Signe Glargaard in Copenhagen, Denmark, with whom we would like to discuss fluid management in patients with heart failure, focusing upon two recent randomized studies, FRESH-UP and TAPIT, conducted and reported by Dr. van Kimmenade and Dr. Glargaard, respectively. Dear Roland, dear Signe, we are very happy to host you tonight. Thanks for taking the time.
Thank you.
Thank you for the invitation.
Very warm welcome from my side as well. As a brief introduction, again, we are very happy to discuss the two studies with you that you both published. Dr. van Kimmenade is cardiologist, as we heard, at the Radboud University Medical Centre in Nijmegen, and is PI of the FRESH-UP trial of fluid intake in chronic heart failure patients. And that was presented at the ACC conference earlier this year, published in Nature Medicine at the same time, so we're eager to hear on that. And Dr. Glargaard is a doctor at the Department of Cardiovascular Research at Bispebjerg, Frederiksberg University Hospital in Copenhagen. I hope I pronounced that correctly. And coordinating investigator of the TAPIT study, which investigated the prognostic effect of upfront thoracentesis of pleural effusion in acute heart failure. And that has been published also highly in Circulation. So we're eager to hear your thoughts on these two trials. And let's start some presentation and discussion.
Again, many thanks for the invitation. I would like to present with you the results of the FRESH-UP study. And I will take you through all the steps that we took in the FRESH-UP study. So what's actually the idea behind the FRESH-UP study? So fluid restriction has been advised for many decades in patients with heart failure on the intuitive assumption that a less fluid intake might prevent episodes of congestion. However, if we look at our own ASC guidelines, they state that patients with heart failure should avoid large volumes of fluid intake. A fluid restriction of 1.5 till 2 liters per day may be considered in patients with severe heart failure or hyponatremia in order to relieve symptoms and congestion. But it is also stated in the gaps of evidence that more evidence on the effects of fluid restriction, dietary salt restriction, and nutrition is desperately needed. So this is why we initiated the FRESH-UP study, the fluid restriction in heart failure versus liberal fluid uptake. So the FRESH-UP study is a randomized, open-label, multi-center clinical trial. And our inclusion and exclusion criteria were actually designed to include the standard heart failure patients. So a diagnosis of chronic heart failure according to the ESC guidelines, more than 6 months prior to randomization, New York Heart Association class 2 or 3, patient should be an adult, and our exclusion criteria were changes in heart failure medication less than 14 days prior to randomization, and heart failure hospital admission less than 3 months before randomization, a coronary or device intervention less than 3 months prior to randomization, hyponatremia at the baseline, which was defined in our study as a sodium below 130, and an estimated GFR below 30 mL per minute per 1.73 square meters. So a typical outpatient stable heart failure patient. Our primary outcome was health status at 3 months as assessed by the KCCQ overall summary score. And we adjusted for baseline values so we could use ANCOVA. And our key secondary outcome was third distress at 3 months, and that we assessed with the first distress scale for patients with heart failure. And look at our study protocol. So we started recruitment in May 2021. Our last patient first visit was June 13 in 2024. And in order to minimize open label effects, we first did a baseline assessment of health status. Then we randomized patients in a one-to-one manner to liberal fluid uptake or a fluid restriction regime. And a liberal fluid intake was defined as intake as according to patient thirst sensation. So there were no upper or intake levels. A fluid restriction was defined as a maximum intake of 1500 mL per day. At week 6, all patients had to report a fluid intake. So, of course, the patients with the fluid restriction regime were recording their intake on a daily manner, but they did not have to report it to us every day. And we decided to have only 1 week of measurements for the liver fluid uptake because we assumed that constantly reporting your intake might also influence the health status of patients, their quality of life. So that's one point. And secondly, if patient had a liver intake but were reporting constantly how much they were drinking, there might be a learning process going on, so that patient might intuitively restrict themselves because they knew exactly how much they were drinking. So we really wanted a real life situation where patients were drinking as much as they wanted. At month 3, there was another assessment of health status, and this was actually the clinical arms. But in order not to miss any safety events, after month 3, everybody was back to the regime as they wanted, or as the treating physician had told them. But we reported events, recorded events up till month 6 of follow-up. And these are our baseline characteristics. Patients were on average 69 years old. 2/3 of them were males, and this reflects more or less a mixed heart failure, HFrEF, HFpEF population. And most patients were New York Heart Association class 2. Average ejection fraction was around 40%. Half of them had HFrEF. The other half had HFmrEF and HFpEF. And ischemic heart failure was the cause in nearly half of the patients. And interestingly, before participation of the study, half of the patients had a liberal fluid intake, so there was no fluid restriction regime, and half of them were on a fluid restriction regime before participation on the study. So patients were treated well. As you can appreciate here, everybody had the 4 pillars in HFrEF. Patients were on chronic diuretic therapy for 40 milligrams of furosemide or an equivalent. In half of the patients. Furthermore, the estimated GFR was around 60, and anti-proBNP levels were around 500, so moderately elevated. So if we go to the primary outcome, if we look at the liver fluid uptake, the KCCQ was 73.4 at baseline and was 74.0 after 3 months of liver fluid intake. While the group of with fluid restriction, the KCCQ was 74.0 on baseline and 72.2 after 3 months of fluid restriction. And this results in an adjusted mean difference of 2.17 points in KCCQ with a p-value of 0.056, which is 0.06. So it did not reach clinical significance. However, I would like to ask your attention for the 95 confidence interval. So this was between minus 0.06 till 4.39. So what does this mean? So this means that the real difference is somewhere between 0.06 higher in the fluid restriction arm up till 4.39 points higher in the liberal fluid intake arm. So 0.06 is not a clinical significant difference in the KCCQ. So we conclude that there is unlikely that fluid restriction will have any benefit in the KCCQ score, that it is impossible, and that our data suggests actually the opposite. This is also seen in our pre-specified subgroup analysis, this trend. And if we look at secondary outcomes, it's clear that the group with fluid restriction had a significantly higher distress. And if we look at the reported fluid intake, so the liberal fluid intake had an average of 1,764 mLs per day, while the fluid restriction group had 1,480 mLs per day. If we look at other KCCQ subdomains, there was indeed a clinical significance in favor of the liberal fluid uptake group. If we look at safety outcomes, and our study was not powered, of course, for safety outcomes, there were no difference in death, all-cause hospitalization for heart failure, IV loop diuretic use or acute kidney injury, which is also reflected in the win ratio of 1.00. If we look at changes in NT-proBNP, there were no differences in NT-proBNP changes. There were no differences in weight changes. There were no differences in loop diuretics increase or decreases or any heart failure medication changes. So we concluded that the difference in KCCQ overall summary score after adjustment for baseline scores after 3 months was 2.17 in favor of liberal fluid uptake, but the primary outcome was not met. Third distress was higher in the fluid restriction group. No differences were observed for safety between groups, and the FRESH-UP study therefore questions the benefit of fluid restriction in chronic heart failure. So let me take you one step back to this Kansas City cardiomyopathy questionnaire. So the Kansas City cardiomyopathy questionnaire is a score with several domains looking at aspects of quality of life, symptoms, and disease. So as you can appreciate here, every KCCQ subdomain has a score up till 100. But they are of course associated. And as you can see here, the KCCQ clinical summary score that consists of symptoms, but also symptom burden and severity and frequency. And we chose to use the KCCQ overall summary score, which also contains quality of life. And this is what we thought was important because we also wanted to investigate if being confronted with heart failure on a daily basis by reporting your intake would influence your quality of life. So if you look at our differences with other clinical heart failure studies, we had a difference of 2.17, which is higher than paradigm of Emperor reduced and almost meets the difference in the DAPA-HF. But one step back again to these KCCQ subdomains. So the FDA, because prognosis in heart failure has improved drastically, and well, in the older studies, you could use as a primary endpoint mortality, morbidity, hospitalization, heart failure events. Nowadays, since prognosis has improved, the KCCQ score has officially been recognized by the FDA as a primary endpoint to study newer strategies, devices, and medical therapy, and especially the total symptom score and the clinical summary score. But what did we actually study? Our hypothesis was that liberal fluid intake would result in a better overall summary score in KCCQ. But one step back, so what is actually the therapy in heart failure? So if you study a new drug or a new device or strategy in heart failure, then you have the population which does not have the disease, and someone from the population gets the disease, and then you introduce this new therapy or medication. So in general population, actually everybody has a liberal intake. And once you become a heart failure patient, then somebody might introduce fluid restriction as a therapy. So actually, what we failed as a heart failure community is once fluid restriction was introduced to actually study the effects. And if you look to the FRESH-UP study from that perspective, the question is, would fluid restriction get FDA approval if we would introduce it according to these guidelines? So the FDA actually only reckons a total symptom score and clinical summary score as a reflective KCCQ score. And if you go back to our data, actually those two subdomains were significantly higher in the liberal fluid uptake. So if we would apply for fluid restriction as a novel therapy in heart failure with the FDA, it would never get any approval. So what's the background actually? If you look at fluid distribution in men, if you take a person of 70 kilograms, which is hard to find these days, by the way, then 60% of this patient is actually total body water. And of the total body water, 2/3 is intracellular fluid and 1/3 is extracellular fluid. And of this 1/3 extracellular fluid, 3 out of 4 is interstitial fluid, and only 1/4 is the intravascular fluid, which might result in problems. So if you would drink 2,000 ml of free water, only 667 milliliters gets extracellular, and of that, only 1/3 is, so that's 167 ml would get intravascular. But intravascular is not a completely activated system, because 70% of your intravascular system is your venous pool in your abdomen, which is actually not actively participating in your circulation. So it's actually a storage. And if you would take that into account, so drinking 200 ml of free water would only result in 50 ml of increase in your effective circulating volume. And this will never result in an increase of your LVEDP, which may cause acute heart failure. So we should bear in mind that your venous planktonic reservoir is very much more compliant than your arterial system, that it contains 70% of your total blood volume, but it can actually move fluid shifts very rapidly, so up to 800 ml within minutes. So if you go back to my calculation in the previous slide, you would have to drink a lot of water to get 800 ml into your intravascular system in order to beat the buffer system of your venous planktonic reservoir. So not only that, but bear in mind that your kidneys clear 180 liters per day. So if you would drink 1 liter extra, this would not result in any problems for your kidney if your kidney function is normal, because your kidney actually clears sodium and water follows passively. So there is no clearance problem with free water as well. So our conclusion was the FRESH-UP study questions the benefit of fluid restriction in chronic heart failure. And if you look at the gaps in evidence and guidelines, please do not see them as a summary of failure, but see them as a source of inspiration. If you like to see more data on the FRESH-UP study, this is the QR code and the DOI, and I'm happy to take any questions.
Yeah, thank you. Thanks a lot, Roland, for this interesting and really pragmatic trial. We at Marcus at Home, we admire pragmatic trials with questions coming from daily practice. Signe, would you like to take the opportunity to make any comments or ask any questions?
Yes, thank you. Thank you very much. Thank you, Roland, for a very nice walkthrough of the FRESH-UP trial. It's a very impressive trial. I know that sometimes pragmatic is also a bit difficult to perform, but I just wonder, I think the thing that struck me the most was to comprehend what the hypothesis was at the beginning, like what was the actual intervention, because as you said, half of the patients were already on a restricted fluid regime. So in some way, if the randomization was balanced, then maybe only half actually changed intervention. I don't know if you follow my thought.
Yeah. Well, that's an excellent question. So there were virtually no data available. So when I designed the FRESH-UP study, this was when I came up with the idea, this was 2018, then the guidelines were actually more strict. So I assumed that everybody would be on a fluid restriction regime. But this was just the assumption. I did not have any data.
Yeah, because in that case, then the allowment to be on liberal fluid intake would be the intervention, right?
Exactly. So our hypothesis was that we would introduce a liberal fluid intake as a novel therapy. But as I showed you in my final slides, actually, this is not the case. I mean, actually, we should have studied fluid restriction in our heart failure community decades ago when we introduced it to our patients to make them suffer. So, but and I was actually surprised that we had such a balanced group. So and this is also the 2022, the Heart Failure Association had a consensus document, and I was one of the authors that stated that there is actually no evidence for fluid restriction and that liberal fluid intake might be as good. And I think that there might be some shift in treating physicians. But I did not have any data. So our primary hypothesis was that patients would feel better in a liberal fluid intake. And on the HFA meeting in Belgrade, we presented actually the switch data. So since actually the pre-study regimes were thus perfectly balanced, we looked at the 4 cohorts. So liberal fluid intake before study, restriction before study, and they were perfectly randomized. So we had 4 equal cohorts, and we saw that those who changed from regime, actually those were the ones with the biggest changes in KCCQ, and this was highly significant. So if you went from a fluid restriction to a liberal fluid uptake, there was a significant high increase in KCCQ, while those who had a liberal fluid intake and went to restriction had a steep decrease in KCCQ.
I think that's an important point, right? Because it reflects the clinical situation you're at with the patient.
Exactly. And another point that was also mentioned and that we could study is that, say, if patients would be on food restriction for years, and then you suddenly introduce this study and patients had a liberal fluid intake, maybe they were drilled by their physicians not to drink too much, so they were not used to drink more than according to thirst. But what's interestingly is that in the liberal fluid intake, if we look at those who had a regime before starting and those who had a liberal fluid intake before participating in the study, they both had the intake of 1,760 mL. So patients really drink according to their thirst sensation. Well, what is interesting is actually that there is a nephrology study that performed in Canada where they did the opposite. So patients with a GFR of 60 or below, and I don't recall the limit, but they investigated how much that patient drank, and everybody was forced to drink 1 liter extra per day. So in order to preserve kidney function, and they looked at it for a year, and patients couldn't do it. They couldn't be forced to drink more. So they saw on average they drank 600 mL more per day. And there were no difference in the primary endpoint, which was more renal function and etc. But what was interesting is that in those who drank more, there was a significant difference in vasopressin levels. So vasopressin was lower in those who drank more, which makes sense, of course, because there is less need to vasopressin. So maybe actually drinking will decrease RAS stimulation and vasopressin activation, and it is actually a good thing to do. It's pure hypothetically, but we should look from another perspective and not just see a patient as a barrel with a tap, which you should fill or filter.
Yeah, I agree. I totally agree. I'll get back to that. But I also wonder a bit if when you look at the baseline characteristic, it's a very stable, well-treated group. And also I wondered the duration of heart failure diagnosis is, I think it was 4 to 5 years, if I recall.
Yeah.
So they also had heart failure. They survived heart failure for a long period, maybe also longer than we sometimes expect. So I also think it's a very stable chronic heart failure group. And also, could you elaborate on why you chose the EGFR exclusion criteria?
Well,
because I get asked that a lot in TAPIT.
Yeah. So there were no other data. So we are now working on a review paper, a systematic review, and there are 4 other papers. And the largest study performed up till now has only 70 patients. So we had to start somewhere, and I was very fortunate to get a first starter grant from the Dutch Heart Foundation, because it's very difficult to get money for this kind of research. I don't know how you did it, but I can tell you that I actually have been making phone calls to mineral water companies to beg for money. So in order to get some starting funding. So once I got the first grant from the Dutch Heart Foundation, I could apply for a second grant because I had some starting seeding money, and this is how I finally got this study going. And one of the conditions, actually, when I applied for the Dutch Heart Foundation is, well, this might be a very dangerous study. Please do not include unstable patients because you might kill some.
Yeah.
And this is the balance that you have to choose between. And if the study would be negative, there would never be a fluid intake study. So this is one of the reasons also to be on the safe side. And if you look at the exclusion criteria, a sodium level below 130, a GFR below 30, and New York Heart Association class 4, this is not 3 exclusion criteria. This is one and the same patient. I mean, a patient with New York Heart Association class 4 probably can have a sodium below 130, but will definitely have a GFR below 30. So this is why we chose this criteria. And I'm still thinking now about doing an in-hospital intervention study.
Yeah.
Roland, can I ask you a question? I'm always wondering in clinical practice if the HFpEF population is more vulnerable to fluid than HFrEF. The reason for that is because we're doing stress echo and giving volume to find out if it's HFpEF. Did you showed us the subgroups and there was no difference. Did you expect a difference between those two populations?
So nobody ever has looked at HFpEF, so also the 4 smaller studies. You can assume indeed, because you have a stiffer ventricle, that a change in fluid will result more easily in an increase in LVADP than in HFrEF, especially if you have a dilated heart. But still, you do this test by giving them intravenously fluid and not making them drink. I mean, and this is key, of course. So if you actually do the math, and compare drinking 2,000 ml of water with giving someone a 24 hours furosemide perfusion, you will actually infuse more intravascular fluid by giving them furosemide than making them drink. So, but this is what I told you. A patient is not a barrel. So we should bear in mind that there are several compartments in the body which with free water can correspond with each other, but it doesn't necessarily mean that if you drink 2 liters of water that it will all get into your intravascular system. And actually on the HFA meeting, there was an interesting discussion with John Cleland telling that there are a lot of hypotheses that in acute heart failure, you might actually get, because of massive diuretics, etc., and therapy, that you get intracellular dehydration, and that you might even have to stimulate patients to drink in order to restore their intercellular volume rather than just giving them only diuretics. So that's interesting theories.
Well, thank you so much, Roland. Terribly pragmatic and very important study. I also have one question. What about that population? I mean, I'm sure you've been asked that a lot of times because you have this rather small difference between 1,500 and then 1,800 milliliters of drinking volume. Then we do see these patients that need 10, 20, 30 milligrams thoracentesis per day because of leg edema, and then they don't stop drinking 3 and 4 liters. What about the totally other end of the spectrum where patients really do drink a lot? Would you hypothesize that there is a population that really needs to a little bit cut down on their drinking volume, and maybe we just follow with increasing diuretics and they keep on drinking even more?
So if I make up my own endpoint, which does not exist, but changes in diuretics in an upper or low, so if I would say need for intravenous diuretics, or compare with increase or decrease in diuretics, then all the higher levels were in the fluid restriction group. So, and this made me think about and looking at these vasopressin hypothesis that by giving diuretics, you might actually stimulate RAS, which you do not want to do in heart failure. So I think that might play a role. Yeah.
I have 2 brief technical questions to the study protocol. So when you refer to fluid intake, that's any kind of fluid intake, including coffee, tea, alcoholic drinks in the evening or whensoever. So it's any kind of fluid.
As Dutch like to consume. So we had a lot of lists where everybody could calculate what that meant if you translate it to liquid. Yeah.
And did you give any recommendations on salt or sodium intake?
Yeah, that's a good question. That's a good question. So we did not, because we did not want to have a 4-arm study. We had a lot of problem getting money for only 2 arms. So, but this is of course next step, and we assume that patient just had sodium as they had before the study, and because of the number of participants, that it would be equally distributed as well. But that's a good question. Yeah. But there was no difference in calculated osmoles at the end of the study. So if there is anything.
Because here again, and we discussed this here time and again with Dr. Silva and other experts, I guess we actually do not really know what to do. And everything we did in the last decades recommending low sodium intake has actually not been shown to give a benefit in adequately powered randomized controlled trials. So maybe actually the same as with fluid intake.
Yeah, so sodium is a different story, of course, because sodium is what the kidney uses to diuresis. But we have the sodium HF study from Justin Ezekevich, and I think he was also in Marcus at Home, who did a tremendous job in studying for 8 years patients with a low sodium diet and a normal sodium intake. But what you see in the sodium HF, what makes it very difficult is that it was very hard to find patients. I mean, the study has been prolonged, and that the patients who participated are I would say, the hipsters among the heart failures. I mean, who are very aware of lifestyle advices, etc. And you see that the control arm actually had a sodium intake of 2.6 or something out of my head, which is extremely low, actually, which is actually below the threshold of our advice. So what you do is what happened is that he compared a low sodium intake with a very low sodium intake. And this is where you did not see any difference. So I'm very curious what will happen if patients will have like 4 grams of sodium. And these studies, I'm trying to design one as well, but these studies have to be done. But it's also very difficult in sodium studies is you cannot prescribe sodium. So you have to give a complete diet and advice, and all kind of other nutritions will change. I mean, and then you are comparing a spinach salad with a pizza in the end. And what are you really comparing? I mean, it's not only the sodium, but it's the complete diet that you are comparing. And that makes it very difficult to interpret.
Well, a lot of answers, a lot of more questions, and we are very happy to hear more from you in the future with all these trials and the setup you've made. And I'd now like to give the ball further to Dr. Glargaard to talk about acute heart failure and thoracentesis, also something that we very much thought is necessary in acute heart failure. If there's pleural effusion, obviously we must drain that or must not. So we're very keen on your talk. Signe, please.
Okay, well, thank you very much for having me. And thank you, Roland, for that very nice presentation. I'll try to walk you briefly through the design and rationale and the results from the thoracentesis to alleviate cardiac pleural effusion interventional trial. We called it TAPIT. And I'm Signe Glargaard. I'm a medical doctor from Bispebjerg, and it was also very nicely pronounced. So thank you for that. But we published the trial in this April in Circulation, and the background for the story was actually a sort of very common clinical question, just like you, Roland. It was decompensated heart failure is the leading cause of pleural effusion. And in patients admitted with acute heart failure, 46% presents with pleural effusion on a chest X-ray. And if you do even more sensitive image modalities, then the prevalence increases immensely. And in 20% of the patients that presents themselves with a pleural effusion, the effusion occupies more than 1/3 of the hemithorax. And the clinical question of this arises from actually a young doctor in our department that asked my supervisor and the primary investigator of the trial, Jens Jakob Thune, if she should perform thoracentesis in this patient. And he said, well, if you ask me, maybe I would say no, but if you ask my other colleague, maybe he will say yes. And I think that's the sort of foundational clinical question behind the trial, is should we perform therapeutic thoracentesis in patients admitted with acute heart failure which presents with a sizable pleural effusion? Thoracentesis, when you do observational studies on the effect of thoracentesis, it causes immediate relief of symptoms, and it improves the patient's exercise capacity. It improves the gas exchange and oxygenation, and also even it improves the ejection fraction a bit. And especially it improves respiratory muscle function. But most studies on thoracentesis are performed in patients with cancerous effusions, malignant effusions, and also infectious. And only very few studies in heart failure where we do have an alternative, which is diuretics and also guideline-directed medical therapy. And it is an invasive procedure with a risk of complications in 1 to 6% of the patients. And this is predominantly pneumothoraxes, and depending on how you define a pneumothorax. But this is approximately the prevalence of complications. And then it has never been compared to standard therapy. So this, again, this is the gap. We have this procedure. We do it as with fluid restriction. We already do it. We already performed it, but we actually do not. We have never compared it to our standard therapy. And the incident rate of thoracentesis in acute heart failure admission is increasing. The first graph you see here is a large American registry study from a health claim registry. And there is a increasing trend. And we have also investigated this in our Danish registries, where we also can see that in newly admitted patients with their first heart failure diagnosis, the trend of thoracentesis increases. So the clinicians use this, and we in Denmark, when we started conceptualizing the trial, could also sense that it was very different from department to department, to doctor, how the practice was. And again, in this case, there were no recommendations, and pleural effusion is not even mentioned in any of these mostly recent guidelines. In the European Society of Cardiology guidelines from 2016, there was a mention of thoracentesis, that it could be performed, and that was it. And then in 2021, it just disappeared. And I think it's kind of interesting with a condition and a symptom that is so predominant when the patients are admitted with acute heart failure. So this was the clinical question. Should it be pill or should it be puncture? And this was what we tried to answer. So we designed the TAPIT trial, which was also like the FRESH-UP trial, a highly pragmatic trial. It was a Danish multi-center trial. It was open label, and it was randomized. It was carried out in 10 cardiology departments across Denmark, so different sites. And our hypothesis was that when you perform an invasive procedure, we would say that referring patients with a sizable heart failure-related pleural effusion to upfront thoracentesis, this should increase the days the patients were alive and out of hospital the following 90 days. That was our hypothesis. Patients was eligible for inclusion if they had a left ventricular ejection fraction at or below 45%. And I think I'll just briefly touch on that because I get asked the question a lot about why did we choose this? And that was because I think a lot, again, like you said, Roland, the fear of not doing your job good enough, and that the clinician, we were afraid to miss any diagnostic value of the thoracentesis. So we had to be very certain that the etiology of the effusion was heart failure and not any other cause. So, and it is, or at least in our opinion, it is a bit more straightforward in a patient with signs and symptoms of congestion with a reduced ejection fraction to establish the heart failure diagnosis, where the HFpEF diagnosis maybe requires a bit more comprehensive either imaging or also examinations before you could sort of establish that it is clearly HFpEF and not maybe the precipitating pneumonia symptoms or something else. So this was the reason we had to be very certain of the heart failure diagnosis. And then the patients had to have a pleural effusion sizable enough that the clinicians would find it clinically relevant to perform thoracentesis and also feasible. So this was the second criteria. as I just elaborated a bit on, we had to, even if it was a pragmatic trial, we had to have some exclusion criteria to ensure, firstly, safety. So a diagnostic thoracentesis could not be indicated, and contraindications obviously could not be present. And the clinicians, again, was very scared of not having the opportunity to refer the patients for thoracentesis. So we had to set some guidelines on when did we think they were too hemodynamic impaired or respiratory impaired for inclusion. And then we had to, again, this is sort of an extra certainty of the etiology. And then we excluded patients with a severely impaired kidney function and patients with prolonged admission for other causes. And in this category, severe aortic stenosis also falls, because if you were admitted with an episode of acute heart failure on the basis of a symptomatic severe aortic stenosis, then a whole nother level of interventions arise where you have to go through valve replacement assessments. So these patients were also excluded. The design was very pragmatic. Patients were screened during admission by the treating physicians at the departments, and they were randomized 1-to-1. We stratified the randomization based on site and whether or not the patients were on anticoagulant therapy. So patients on anticoagulant therapy could be included because this is the patients. They are on anticoagulants. So excluding them from the trial, at least we believe, would, in this pragmatic design, give a false group or a more selective group. Then they were stratified, they were randomized to standard pharmacological therapy or pharmacological therapy and a referral to upfront thoracentesis. So this was a sort of a strategy design. We could not decide if the radiologist had to do the puncture, but it was the initiative to refer the patient to thoracentesis. Then all patients had standard workups performed, and the treating decision decide their discharge timing. Then we assessed quality of life also by the KCCQ at day 14 after discharge and day 90 after randomization. And we assessed the health records for data regarding mortality and readmissions in the period for the primary outcome. The primary outcome was chosen because we wanted an outcome to reflect both overall health burden, but also to incorporate both the possibility that thoracentesis shortened the primary index admission, but perhaps caused readmissions due to reoccurrence of the effusions. And we wanted it to incorporate mortality. So we chose days alive and not out of hospital during 90 days. And the study was powered to show a 3-day difference in this primary outcome. Key secondary outcomes was duration of the index, admission, mortality, and quality of life. And during a 2.5-year period, we started our first randomized patient was in August 2021. So we initiated the trial during in the tail of the COVID pandemic. However, I think it did not have any implications on the process. We initiated just after, but it took us 2.5 years to include the patients. We included 136, and 67 were randomized to the control group and 68 to the intervention group. And the design was protocolized that the referral was the strategy. Like the strategy of referral patients with thoracentesis was the intervention. And then 59 patients actually received thoracentesis in the intervention group. And in the control group, 62 patients actually only received medical therapy. In the protocol, this was not defined as crossover because it was the strategy of referral that was the intervention. However, one should bear this in mind. And in 7 of the patients that did not have thoracentesis performed as an intervention, it was because the radiologist did not find a sizable enough effusion to place a drain safely. And in this patient group, they waited a median of 48 hours before they were assessed for the procedure. The patient that did undergo thoracentesis had a median of 1 liter drained, and 68% had over 500 milliliters drained. And they were all analyzed according to the attention to treat principle. So baseline characteristics were well balanced. I'm just going to show you a few. This is maybe the opposite, the non-vogue population, Roland. A median age of 81, and 50% was categorized as vulnerable or frail on a clinical frailty scale. 1/3 was female, and 50% suffered from new onset heart failure. And they had a severely impaired systolic function, I would say. 70% presented with bilateral effusion, and this extrapolates well to what have been shown prior in heart failure populations. So this is very normal that 70% is bilateral and the rest is unilateral, most predominantly right-sided. And 50% were on anticoagulant therapy. They had very high NT-proBNP, reflecting an acute heart failure episode, and a mild to moderate affected kidney function. So the primary outcome was days alive out of hospital, and this is the distribution of the outcomes between the two groups. And the control group had a median of 82 days alive, and the thoracentesis group had a median of 84, and there were no difference in distributions. Then the secondary outcome was the length of the index admission, and I think we in the investigator group actually thought that perhaps a shortened length of index admission would be the primary driver of any difference in the primary outcome, as we would think that the intervention would give the patients rapid symptom relief and maybe faster discharge. But the median days admitted was 5 in both groups. And similar with in-hospital mortality, which was 3% in both groups, and 90-day mortality, which was 13% in both groups, with no difference in survival probability during the 90 days. So this is the results of the quality of life questionnaire, and this is a complete case analysis. And the response rate was low, as this was a very vulnerable, frail population. So this is these results are also prone to survivor bias and attrition bias. However, we saw no difference between the groups. And as you said, Roland, we both our pre-specified secondary outcome was the overall summary score, but we were also asked to report both the total symptom score and the clinical summary score, and there were no difference in the groups. So we asked ourselves, why was TAPIT a neutral trial? Well, first of all, did we choose the correct outcome? And I think you can always discuss that, but we chose in this unblinded trial outcome that reflected several sort of possibilities of the effect of thoracentesis. And I think it was highly clinically and patient relevant. So I think we believe that we did choose the correct outcome. Did we have enough participants or enough power? Well, as you, Roland, there are very little data on this group, and most epidemiological data on thoracentesis in malignant effusions. So we believe that I think the variation in the primary outcome was greater than we anticipated, possibly reducing the power from the 90 that we had planned. However, then you can say, was it the study execution? Did we deliver a good enough intervention? I believe that 22 hours from randomization until thoracentesis was very fair. Considered the logistics around performing the procedure in patients, and considering that half the patient had to pause anticoagulant therapy before the procedure could be performed. And also median liter drained is also in coherence with other observational studies shown that in this range of volume, the patients do experience symptom relief, significant symptom relief. So I think we managed to perform a quality intervention, and at least an intervention that mimics the clinical reality as it is now. Then there's the possibility that the crossover, the move from thoracentesis to no thoracentesis could have affected the study. But we did an as-treated analysis as well, and the results are similar. So maybe is it because that there are no effect of thoracentesis in these patients? And I think what points to no effect based on the TAPIT trial is that we saw no signal of an effect in none of our selected outcomes, primary or secondary, and none of the pre-specified or ad hoc subgroups afterwards, not in patients with anticoagulant therapy versus no anticoagulant therapy, new onset heart failure versus chronic heart failure. So I think we, based on the TAPIT trial, concluded that in patients admitted with acute decompensated heart failure with reduced ejection fraction and a sizable pleural effusion, that routine referral to upfront thoracentesis did not change the number of days the participants were alive and not hospitalized. So we saw no effect and no benefit across the secondary outcomes, including the length of index admission and mortality. So I think we concluded and would recommend that you do not routinely refer patients to upfront thoracentesis. So what are the clinical implications? Well, I would like to show you this. After the publication of the trial, there were a bit of traffic on social media, and I think this sums it up really nicely, the question. This colleague says, what? I spent years performing it very rarely in Spain, and I came to Germany, and it was considered criminally not to do it. So I think this is sometimes what you're up against is what is the practice? And we need to try to investigate these sort of practices to maybe get in coherence with each other. So I think we discovered a real clinical problem that the clinicians would like us to answer. And when there are no clear guidelines, then you also experience immediate impact. And I'm really happy that during the publication of the trial, I participated in the podcast with the editor of the handling editor of the trial in circulation. And he said, I got to use the results today. And I think that's what you want to hear when you have used 4 or 5 years of your life conducting a study, is that your fellow colleagues actually needed the answer to the question or could use the results you presented. And it had a lot of impact. And I'm really happy that I was also invited here and to be able to share our results with you. And I think this is what we can conclude. And it's not a real recommendation, right? It's one small pragmatic clinical trial, but at least we are perhaps onto something. And there are still several subgroups we need to investigate where thoracentesis might have a benefit. I have to thank a lot of people that participated in the trial and also all of my collaborators on the trial. And I'm happy to answer any questions if you have.
Well, thanks a lot, Signe, for that brilliant trial, and again, a data-free zone, and now there's some. Roland, would you like to take the opportunity to start Q&A session and comment on that?
Yeah, sure. So, Signe, congratulations. I love your data. I love your study. And many aspects why I love it, not only because we're not competing for the patients, because there were definitely different inclusion criteria. I like how you show that there is no clear evidence for evacuation of pleural effusion. You also myth-bust the effect of acupuncture in heart failure, actually. And I think these data perfectly fit in what we were discussing earlier, that acute heart failure is not overfilling per se. So if you look at patients who get admitted with acute heart failure, in the days before their admission, they not increase in body weight or whatever. That's a very poor predictor of acute heart failure. Acute heart failure is not overfilling, but it's maldistribution. And this is what you show brilliantly also in this study. So compliments for that. So what always is my question with pleural effusion, do you think it's a symptom of left ventricular failure or right ventricular failure? And in regards to that, how do you think about ascites? And would you like to reconsider your first answer then?
Today I chose mainly to focus on the trial, but I did, as a part of my PhD, we did conduct a cross-sectional study actually in around 350 patients admitted for right heart catheterization during their evaluation for advanced heart failure workup. And because nobody knows, that's the first answer. But in that study, that was predominantly stable outpatients on optimal medical therapy referred to right heart catheterization as part of their workup. And in that study, I found that if you, within one to 2 days of their right heart catheterization, if they had pleural effusion on the X-ray, and we made a radiologist grade it by sort of a visual, semi-quantitatively score, that there is a association between increased pulmonary capillary wedge pressure and the occurrence of pleural effusion. And also in a logistic regression analysis, there is a 6% increased odds of having a pleural effusion for every 1 millimeter mercury increase in pulmonary capillary wedge pressure. And similar with the central venous pressure, actually. We saw that an increase in central venous pressure was also associated with increased chance of having a pleural effusion, or associated with increased odds of having a pleural effusion. And I think what I have learned the most is that I think both is correct, because pleural effusion is predominantly formed under normal conditions from the parietal pleura, where the capillaries arise from the systemic circulation, and then it's drained by lymphatics to the central vena cava, to the superior vena cava, I'm sorry. So increased pressure on the right side could cause impaired lymphatic drainage of the effusion from the pleural space. And I see in experimental studies and in our right heart catheterization studies, there's coherence that shows that around 14-15 millimeter mercury of central venous pressure, then the venous, the lymphatic drainage of the effusion is impaired. So I think right-sided increased pressure due to volume overload or congestion could cause effusions, and also right heart failure could, because a venous stasis to the systemic capillaries in the parietal pleura could cause pleural effusion. However, I think in systolic heart failure, I think it's predominantly the increase in pulmonary capillary wedge pressure that causes fluid transduction into the pulmonary capillaries, and that flows to the pleural space. So it's both sides. It's a dual. It's trapped in the middle, the pleural space. So I think both are the case. And then you asked me about, I think the initiation of the pleural effusion formation is initiated by, as you say, maldistribution, but also increased left-sided filling pressures, but could be worsened to a larger degree by increased central venous pressure. And then regarding ascites, I would say that at least, I think sometimes you should be very sort of careful to think that if you see a patient with a pleural effusion who has also ascites, that what comes first, is it the stasis in the liver and the gut and the transduction from the gut and the ascites that transfers to the pleura, or is it in the pleural circulation? Because patients with severely chronic liver failure and portal hypertension, they also get pleural effusion, but it's simple transduction above and below the diaphragm of the fluid. So I think there are a lot we don't know about this sort of, I don't think it's too closed off compartments, so that makes it even more complicated, I would say. So as you said, it's not just pumps and pipes, it is really a complex process. And we also examined in the pressure study we did, we also examined the association of albumin levels, and we can see that lower albumin levels, independent of pressure, is also associated with medium or large size pleural effusions. So there are definitely a lot of things we do not know about how this phenomenon.
Wow, that's very interesting. Very nice to hear this summary also on hemodynamics, which I love. So what was usually prescribed as standard pharmacological treatment? Was it diuretics? Was it colchicine? Was it?
Standard pharmacological therapy. It was decided by the clinicians, but I think that the clinicians are very well within the guidelines. So it is what is predominantly intensification or initiation of loop diuretics. Some also was administered thiazide, but not very many. And then it was, I think, rapid and early initiation of guideline-directed medical therapy or up titration of an already existing therapy. So that was the main treatment.
So some question about the KCCQ. So I believe that I saw that the first interrogation was 14 days after therapy, right? You did not have any KCCQ data before randomization.
No, unfortunately not. And that's where as you say, the funding and the pragmatic trial becomes a bit challenging. So no KCCQ before. So it is a single score assessment. We have not done repeated measurements. It is a single score assessment on day 14 and on day 19. We've not assessed change in score as we have no baseline value. So unfortunately, that was not possible for us. And we did choose the 14 days after discharge because we wanted we wanted to get as far away as from the unblinded intervention but still we wanted to assess patient in an time span from where they were considered out of their acute phase. A clinician had thought these patients were stable enough to be discharged. And then we would like to assess the first 14 days here as the sort of closest time point to the intervention.
I fully understand the issue, and this is what we have in these open label trials that we are doing, where everybody thinks that it should be double blind. But in the other way, like TAPIT and FreshUp, there is no commercial incentive in these studies. I don't care if we would have shown that food restriction would work. You wouldn't have be sad if you would have shown that pleural evacuation would work. I mean, and this is the opposite, of course, in the double-blind studies with a pharmacological drug with a company behind it.
Yeah, I agree, and we can't totally dismiss that perhaps some clinician had an incentive to discharge early or readmit, but I think that's also a very theoretical and academic bias.
Exactly, and the other way around is show me the evidence that fluid restriction or pleural evacuation does work. I mean, anything we have shown that it didn't work.
And I think especially in the way this was also, as you say, when there are nothing else to sort of work upon, this was also a way to examine what we do now in Denmark. This is the practice we do in Denmark. This is how we choose the patients. We choose them based on predominantly based on a standing chest X-ray, which is not very good at quantifying pleural effusion, but that is what the clinicians do right now. So this is how we choose the patient, and this is the way the intervention is also performed logistically in Denmark, at least. So I can't say there are still areas in this where thoracentesis might turn out to be beneficial if you could do it really upfront at the emergency department, perhaps. In patients that did not require anticoagulant pause, that were considered diuretic resistant or had very large effusions, which were excluded in this trial. So I think there are areas we still do not know enough about, but this was sort of the standard group of patients we at least consider referring to upfront thoracentesis that we have now investigated.
Can I ask you a theoretical or a technical question? How much courage did you need to choose this primary endpoint, which I like, but I think there must have been some discussions about including mortality, or was that straightforward decision to include it?
I think it was quite straightforward in the way that we wanted to sort of, I think it's a good endpoint of the fact that it captures a lot of it. And I think the most important thing for the patient is, do you survive? So in a way, I would also say that sometimes other endpoints suffer a bit from, what about the patients that die before they reach the endpoint, or before they can report any endpoint? I would say that there are the really severe cases. So I think that was the thought, and I think the thought was that if you should perform an invasive procedure that has complications, and also in some cases there are fatal case stories from thoracentesis. It is generally considered safe, but there are serious complications, and there are also just a minor discomfort and minor complications in the large group of patients. I think in our trial, 25% reported some sort of minor complication, need of analgesics, mechanical problems with the drains. They had to have it reperformed, stuff like that. That is, I think, a burden to the patients. So I think if you have a procedure like that, you also really have to show a significant benefit on a really patient-relevant outcome, I would say. At least that was our considerations, at least regarding the primary endpoint.
Well, Senior Roland, as you can see and hear, I think we can chat on forever, and we really appreciate the way the two of you get into discussion and as true experts elaborate on these fields. I mean, wow, this has really been two very, very pragmatic, neutral trials that show us what we don't have the evidence for and what we maybe should not do. Perfect. I mean, this is scientifically very, very interesting, and also just for our daily practice. So thank you very much indeed for conducting these trials and for being with us and discussing them so extensively, and for sharing your insights. We're very much looking forward to hearing more from you, sub-studies and further studies to come. And well, thank you.
Oh, thank you for the invitation and the podium.
Yeah, thank you.